All right, so for your guys' review, it's really pretty much split into psychiatric medications and cardiac medications. Specifically, when we're talking about psychiatric medications, a lot of the abnormal psychiatric processes you guys will learn about in your psychiatric mental health nursing class. Additionally, we're really with psych paying attention to what's it treating and what are some possible adverse effects, if you will. So, with our psychiatric medications, we really want to be monitoring for our signs and symptoms of our TD, which is our tardive dyskinesia, our extrapyramidal symptoms, and our pseudo-Parkinson's. Additionally, a huge black box warning for psychiatric drugs is that they can worsen suicidal ideation or they can worsen depression. So us as nurses, we are going to be frequently doing some psychological assessments on these patients. Again, if you're just now joining me, please sign in. The link should be in the chat. If you need me to send it again in the chat, just pop that in the chat. Additionally, if you have any sort of questions, please let me know, and I will be more than happy to answer them. Okay? So let's go ahead and begin. Just a quick word about our antipsychotic medications. When we're talking about schizophrenia, we really treat schizophrenia with antipsychotics as opposed to some antidepressants. Because with schizophrenia, we've got kind of two things happening. We've got these positive symptoms, which kind of that's what we notice. We notice the patient is not sleeping and they're talking to people and they're hallucinating and just lots of different obvious symptoms. That's what we call positive. Negative, on the other hand, this is when your patient might feel more sedated, more withdrawn, have more of those depressing thoughts. So it's a little bit hard to pick up on those negative symptoms. And ideally, we want a drug that works with both. However, we do need to be cautious about some of our side effects. Okay? And these are our medications in a nutshell, if you will. Or not our medications, our side effects, really are pseudo-Parkinsonism. This is just Parkinson-like symptoms that's due to psychiatric medications. The patient doesn't have Parkinson's, but it almost looks like they do because those meds are giving off those weird pin-rolling tremor, shuffling gait, etc. Additionally, our acute dystonia, this is more of our neck and face grimacing symptoms. Akathisia is just your patient's kind of shaken, constantly moving. And then finally, our tardive dyskinesia. This is when you might see them smack their lips a lot, stick out their tongue, just a lot more involuntary movements of the face. So be familiar with some of these signs and symptoms. When we're talking about fluphenazine, also known as proloxin, this is a really good antipsychotic for schizophrenia. However, this is a typical antipsychotic. So typicals only treat our positive symptoms, our above the personality symptoms. Additionally, this med has very low sedation and can help with act as an antiemetic. Unfortunately, it's got our anticholinergic side effects, such as our dries. And a big side effect, like I talked before, is our extrapyramidal symptoms. So it's going to be really important we recognize what EPS are happening. Is it tardive dyskinesia? Is it pseudo-Parkinsonism? Is it akathisia? What's happening? Because we might have to kind of tailor the dose, okay? So really, big picture, notice your extrapyramidal symptoms and know what this drug treats. Is it going to help with those negative symptoms? No, it's not. Okay. When we talk about haloperidol, this is another typical antipsychotic. It just works on a different receptor in the brain. So again, typical, they only treat positive. What are we watching for? We're watching for extrapyramidal symptoms. One thing we need to keep in mind about our Hadol is you can't take it with antacids. It's going to make it ineffective, okay? And with a lot of our antipsychotics, they do take time to work. They're not going to work right away, all right? However, our atypical antipsychotics, these treat both the positive and the negative symptoms. So they treat kind of the crazy above the personality and the below the personality, where the patient's just kind of withdrawn, sedated, depressed, things like that. Additionally, this drug is better because they have reduced incidence of these APS. So it's just going to be on a lessened extent. So it's a lot more livable and manageable for these patients. Big side effect is going to be our photosensitivity. So teach them to practice safe sun, wearing sunscreen, long sleeves, a wide brimmed hat, all things like that. And this treats above and below. So be prepared. There might be questions where you're going to have to choose which drug's going to be best for your patient. And as nurses, we have to advocate for the best meds for these patients. If you know your patient's having both positive and negative symptoms, well, yeah, I'm going to want an atypical, but maybe they only need a typical antipsychotic. So just kind of be familiar with that. A word about anxiolytics. All anxiolytics, what do? They relax us. They act on the central nervous system to produce a sedating effect. So keep that in mind. They're going to be drowsy. They're at risk for falls. We don't want them driving. Things like that. Specifically, what happens when you just depress everything and you sedate everything? What do you think that does to our respiratory center? Kind of drops it. So really watch that respiratory rate. Lorazepam, also known as Ativan, is a very good, quick-acting benzodiazepine, and it's really used for a wide variety of things: anxiety, generalized anxiety disorder, and seizures. It increases GABA. GABA is good. GABA calms the nerve activity in the brain, okay? Again, what is our big nursing consideration? Watch the respiratory rate. If you start seeing your respiratory rate drop to like 6 or 8, we're going to want to administer flumanazole. This is what's used for a benzo overdose, okay? And it's absolutely contraindicated when using kava kava. Another really good anxiolytic is buspirone. Again, this one is used to treat kind of the same things, but this one doesn't cause that CNS depression, so we're not super worried about that drop in respiratory rate. One thing to know about this drug, you cannot have any grapefruit juice. However, unlike your lorazepam, that might be quick acting, buspirone does take a little bit of time to work, okay? It might take 1 to 2 just to exhibit minimal effect, and maybe you won't even notice its max effect till 4 weeks. So again, what does your patient need in the moment? A word about antidepressants. A lot of our antidepressants that are most common ones are our NSRIs, or SSRIs, sorry. They help with serotonin. Serotonin's that, thing that makes us feel super happy. But too much of a good thing isn't a good thing, and we're really concerned about a serotonin overdose. Now, why would this be bad? Well, essentially, your body is way too excited everywhere. So we use the term wet dog shakes. These people will be panting and grinding their teeth like a dog. They're going to be very, very, very sweaty, and they're going to be trembling, okay? So just keep that in mind. Your amitriptyline and imipritylene, these are our TCAs. They're usually reserved for major depressive disorders, okay? They're not generally prescribed to those who have generalized anxiety disorder or are depressed. It's usually kind of a last resort because it's got lots of bad side effects, okay? Big thing is sedation. Watch that respiratory rate. It's got that anticholinergic dry effect. Really, really high risk for those extrapyramidal symptoms, okay? But what are we concerned with? A serotonin overdose. So that can kind of happen when you are taking an MAOI and a TCA. They're absolutely contraindicated in each other. You have to wait 2 to 3 weeks before starting and stopping. So if I'm on an MAOI and I'm being put on a TCA, I have to stop my MAOI, wait 2 weeks, and then start my TCA, okay? So just keep that in mind. Why? Because a TCA, it blocks the reuptake of serotonin. MAOIs also increase serotonin. We have way too much serotonin if we're double prescribed. Prozac is one of our most common drugs. It's our SSRI, also known as, and it's also known as fluoxetine. So again, just watch their serotonin levels. While we do want to increase serotonin levels to kind of reduce that, anxiety, depression, things like that, again, too much of a good thing is not a good thing. So what are we going to do? We're going to make sure my patient's not taking an MAOI, they're not taking St. John's wort, and we're going to watch for serotonin syndrome. Additionally, these have a lot of signs and symptoms and side effects, but they usually dissipate, so that's a good thing. But it does take a little bit of time for the meds to work. Our SNRIs, this is just norepinephrine is now being involved. So again, same situation, same uses. This can cause a bit of photosensitivity, and if your patient is on an SNRI, we do need to be watching the sodium levels, because sodium levels can drop with this drug. Okay, so just keep that in mind. Again, we don't want to put the patient on lots of meds that interfere with serotonin because of that risk for serotonin syndrome. Okay? Usually this is not good for kids. There's very few. So without further ado, let's hop back into MAOIs. So MAOIs, these are our no popular meds, are Nardil, Parnate, and Marplan. These we rarely ever give an MAOI because honestly, the side effects are very, very, very bad, as evidenced by a hypertensive crisis. Hypertensive crisis, if left unmanaged, leads to death. Okay. Additionally, there are so many contraindications with these meds. You can't have tyramine foods. That's your charcuterie board. What do we like? Aged meats, cheeses, wines, all that good stuff we love. Can't have it if you are on a MAOI. Okay. So additionally, what we want to do with these drugs is we also want to basically go ahead and don't worry about me pausing. You guys are more than okay. I am here for you guys.
I waste lifelines.
Okay. Alrighty. So, again, tyramine foods, super contraindicated. Any TCAs, other antipsychotics, cold medications, all of that can cause really, really bad side effects, such as a hypertensive crisis. So, again, mood stabilizers, these are usually used for bipolar as well as some depressive disorders. So just kind of keep that in mind. Lithium is our drug of choice for bipolar. This really helps manage that mania and bipolar disorder. What is bipolar? You have these episodes of mania where they're up for multiple days at a time, artistic, all the above, followed by massive depression, sleeping, things like that. So they have highs and they have lows. Our goal with treating bipolar with lithium is to just kind of get them in a nice, stable, mood, okay? Hence, mood stabilizer. We don't want highs, we don't want lows. We just want to ride the line, okay? However, this can cause circulatory collapse, so just keep that in mind. Other side effects your patients might report can be a metallic taste. Again, really be careful with meds. Usually if they're on lithium, we only want them on lithium. We don't want them on anything else, okay? There's a very narrow therapeutic range for lithium, so just closely monitor it. Anything 1.5, greater than 1.5 is considered toxic. So when you might suspect a patient has lithium toxicity, you might not even have your labs back, but if they start having this tinnitus, ataxia, dysrhythmias, seizures, all of that, we want to immediately hold the next dose and we want to get a lithium lab on them. We also want to make sure that they frequently stay hydrated. Okay. So now we're going to talk about medications for pain, fever, and inflammation. Anti-inflammatories typically have our COX-1 inhibitors, or COX-1 and COX-2 are our main inflammatory processes in the body. So by blocking COX-1 and COX-2, we're going to block that inflammatory process. Specifically, COX-1 coats the stomach, so it's that protective stomach lining. So if we have a COX-1 inhibitor, we're going to block inflammation, but also we're going to lose some of that protective stomach lining, so these patients are at risk for gastric ulcers, things like that. COX-2, this is the one we really want to block, okay? Additionally, these meds can be toxic at high doses. We'll talk about aspirin. Aspirin is absolutely contraindicated in children. So, speaking of aspirin, it helps block COX-1 and COX-2. Additionally, aspirin not only blocks inflammation, but it's kind of one of our drugs that has multiple different effects. So later on, we're going to talk about aspirin when it's used as a antiplatelet. But if we're using aspirin for inflammation and fever, again, great drug. It's got a lot of different uses, okay? Keep in mind, though, if they're on it for like an inflammatory reason, they do have a side effect of bleeds just because it has that antiplatelet effect. Really, we need to monitor for toxicity because this can lead to salicism, which can ultimately lead to circulatory collapse, okay? Blood pressure bottoms out. So not only are we monitoring their levels of aspirin, we're also looking at PTINR. Okay, again, aspirin is a great drug. It's generally pretty safe. Lots of patients are on it, more for that antiplatelet effect. Just keep in mind, while aspirin is used to be an antiplatelet, it can also be an antipyretic, which is for fever, and an anti-inflammatory agent as well. Ibuprofen, this is our first generation anti-inflammatory. So all this does is this helps with fever and inflammation, okay? However, this drug is pretty nephrotoxic and it's also pretty hepatotoxic. So we do have to take the recommended dose, all right? Big contraindication is liver impairment as well. Again, we usually recommend they take this med with food because it's not very nice on the stomach, okay? Siloxib, this is COX-2, so all it does is block the enzyme that triggers pain and inflammation. So this isn't going to have that effect on the stomach. So this is generally a better drug, especially if our patient has like a history of gastric ulcers, GERD, things like that. This one is specifically used for more of our arthritis because, again, it's just that COX-2 inhibitor. Big side effect is GI upset, and we really want to watch for a GI bleed. Even though it doesn't involve that COX-1 pathway, this is why we take all of our anti-inflammatories with food because they're just irritating overall, okay? And then finally, we have oral corticosteroids. Our oral corticosteroids are usually used for if someone has like massive inflammation or an inflammatory disorder because these stop all the pathways and it works on everything, okay? Big side effect of these drugs is going to be our hyperglycemia and our Cushing syndrome. So just kind of take everything we've learned about those diseases and apply it to this med. So again, you must taper. These patients are at risk for infection, watch their glucose level, and things like that. You guys should all be pretty familiar with those drugs. Parenteral corticosteroids, these work ASAP. If you got stung by something, you got bit by something, and you are massively swollen up in like your leg or something like that, they poke you with a parenteral corticosteroid, and it works really, really, really well. Again, it's still a steroid, so we're still at risk for Cushing's. What do we do if our patient has Cushing's? Well, or if they're on steroids, steroids suppress the immune system. The immune system is what's responsible for inflammation. So treat these patients as if they were immunocompromised. And now we're going to talk about gout. Essentially, you need to use these meds in combo with dietary changes. So what is gout? We'll talk about gout a little bit more in this semester, but essentially what happens is uric acid likes to build up and cause a lot of pain in the joints. Specifically in that greater toe, they'll have a really, really bad debilitating pain. This again, usually because of that buildup of this uric acid. Okay, so what are we going to do? Well, these drugs work to help reduce the amount of uric acid buildup. So, again, it's a great drug, but it has to be used in combination with diet therapy. Okay, so what's happening with this drug is it's just going to help block the formation of uric acid. Okay, however, we can't have this and also consume caffeine or alcohol, and frequently with all of our anti-gout meds you need to get your vision checked because it has a negative effect on the eye. Again, very contraindicated in lots of different foods, specifically our organ meats and foods that are high in uric acid. So just familiarize yourself with some of that and really, really, really get those yearly eye exams because gout meds are not safe, like they're not good on the eyes. Now we're going to specifically talk about pain. One thing to note, pain is completely subjective to the patient. They know their pain the best. If they're telling you it's a 10, you're going to treat it like it's a 10, regardless of anything else. You might say, oh, their heart rate is like fine, like blah, blah, blah. Pain is what your patient says it is, okay? Additionally, always assess your old carts. Big thing about pain meds is they do have a pretty high risk for making your patient pretty constipated. And then specifically with morphine patches, we rotate the sites and we must wear gloves. Additionally, analgesics can also be very, very toxic in high doses because they are very, very harsh to the liver. If you have acute liver impairment, your whole body's going to fill up with toxins, and that's not good. So our most common analgesic is acetaminophen, also known as Tylenol. Tylenol is not an anti-inflammatory. This is just for pain and fever. It does not help with inflammation. So if you have a problem that's due to inflammation, giving them Tylenol is probably not going to help if the pain is due to inflammation. Okay? Additionally, these can be used for mild to moderate pain. But again, please, please, please remember this. It's not an anti-inflammatory. So if your patient has a swollen ankle from like twisting their ankle, you're going to want to give them ibuprofen, not Tylenol, okay? Tylenol is usually used for like headaches, generalized pain, things like that. It is nephrotoxic and hepatotoxic, okay? Really, we have to watch for an overdose. Our max dose is 4 grams a day. If you do suspect an overdose, they're usually going to have a lot of tummy pain, okay? And again, the symptoms range from pretty mild to pretty severe as these toxins begin to build up. Our antidote is going to be N-acetylcysteine, so please keep that in mind. We always want to know if a drug has a antidote, what is that antidote? Because if your patient has a prescription for that drug, they're also going to have a PRN prescription for the antidote, okay? At least in the clinical setting. Morphine, this is used for our severe pain. However, morphine can cause respiratory depression, so monitor that respiratory rate. If your patient's respiratory rate is 10 and they're complaining of pain, we're not going to give them morphine. Even though they're telling me their pain is a 10, yes, I want to work on their pain, but I need to give them a pain med that's not going to cause respiratory depression, okay? So usually when you're administering this med in your med Pyxis, you'll have to input what their respiratory rate is because, again, it's a safety protocol. Also, we never give morphine if our patient has a head injury because it kind of can decrease your level of consciousness. Well, what's one thing I'm concerned about with head injury? Signs and symptoms of increased intracranial pressure. Our first symptom of increased ICP is an altered mental status change, decrease in the level of consciousness. They're not alert and oriented. We're not going to give morphine to a patient with a head injury, even if they're in really, really bad pain, because I need to monitor your LOC. We know morphine drops LOC. Okay? So again, monitor your pulse ox and your respiratory rate. Naloxone, also known as Narcan, this is our antidote for an opioid overdose. Okay? So if we go back, morphine, and someone has a morphine overdose, we're going to go ahead and give them Narcan. Okay, this really, really helps reverse the signs and symptoms of that respiratory depression. Okay, also if someone's going through opioid withdrawals, this can help too. So now we're going to talk about cardiac medications. I have them split up into 4 main categories for you guys. I have your hypertensive drugs, your drugs for heart failure, your drugs for myocardial infarction, and your drugs for atherosclerosis. Keep in mind, a lot of these drugs do overlap. Why? Our big contributing factor to heart failure is chronic hypertension. So chances are you're probably going to be on meds for both. Big complication again, hypertension puts us at risk for MI, so they're probably going to be on both. So just keep in mind, keep an open mind that lots of these drugs are used for lots of the same things. Okay? Word about cardiac meds. Cardiac glycosides help with contractility. So with heart failure, when my heart just isn't contracting as well, we give some cardiac glycosides. Black box warning, all antidysrhythmics can worsen dysrhythmias. Yes, amiodarone is an excellent drug that helps us with our dysrhythmias, but can also put our patient in a really bad dysrhythmia. And really review how your anti-anginal drugs should be used. Specifically our nitro. And before giving any cardiac med, we always have to assess heart rate and blood pressure. The whole purpose of these cardiac drugs are to help drop the heart rate and drop the blood pressure. Well, by dropping blood pressure, we drop the heart rate. So if our purpose is to drop that, is it a good idea if I give my patient lisinopril if their BP is 90/40? No, we're going to bottom them out. So please, 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 always assess your heart rate and blood pressure before giving a cardiac med. Thank you. First up is digoxin. This is our cardiac glycoside. Digoxin can be used for dysrhythmias. Digoxin also, we see nowadays, it's more used in patients that do have heart failure because it improves that contractility. Again, a big, big side effect is our dig toxicity. Again, monitor this therapeutic range. We want to keep it between 0.8 and 2. What do we do with dig toxicity? We're looking for new halos, nausea, vomiting, diarrhea, confusion. One thing to note is that hypokalemia worsens dig toxicity. So if my patient is on digoxin, I need to be watching their potassium levels. Why am I watching their potassium levels? If my potassium is really low, it's going to cause my digoxin to just spike up, and that's not good. We need them to balance each other out, okay? So what do? We check our pulse before giving it, make sure my patient's eating nice, adequate vitamin K, but in the event my patient's blood pressure and heart rate is low, I'm not giving this drug. Okay? Amiodarone is a very, very good antidysrhythmic drug, specifically used for AFib and aflutter. Keep in mind, this is a very photosensitive drug, so again, practice your safe sun. When I say photosensitivity, it means that they're very sensitive to the sunlight. It's going to burn them. Their skin is just a lot more sensitive. Additionally, this can cause some blue-gray discoloration and in rare instances, acute respiratory distress syndrome. So if your patient is on amiodarone, we want to do a cardiovascular assessment, but we also want to do a respiratory assessment. Up next, we have nitro. Nitro is a very, very good drug for it's a very potent vasodilator. So if my patient's having unstable angina or an acute MI, we're going to want to give them nitro to just kind of help dilate and open up those coronary arteries to allow blood flow to get into the heart. Big side effect of these drugs is a wicked, wicked headache. So if your patient is going to take this drug, make sure they're sitting down, as it can also cause dizziness. It's absolutely contraindicated in ED meds, erectile dysfunction, such as Viagra. Those meds, absolutely contraindicated. What are we going to do? We're going to teach our patient how to take their nitro. What you want to do is you want to take one under the tongue every 5 minutes. You max out at 3. If you've taken your third and it's been 5 minutes and you're still having chest pain, you need to call 911, because this is not unstable angina. You are having a myocardial infarction. A word about diuretics. These patients are usually on fluid restrictions. What's the whole purpose of a diuretic? It's going to help diurese you. It's going to help you pee. It's going to tell the kidneys to really get more water and release it through the urine. Okay, so really we're going to want to do daily weighs, watch for dehydration, and watch your electrolytes. Our thiazide diuretics, these are our most common diuretics. They really help with hypertension, because what might contribute to an elevated blood pressure? If someone has fluid overload, they just have more fluid pumping through their body. So keep that in mind. It's contraindicated for those that have sulfa allergies, so just keep that in mind. And again, we get their baseline vitals, we're doing daily weighs, we're doing INOs, and we are really just making sure that this drug is working. How do we make sure it's working? Well, the goal is, if my patient is on a diuretic, that they lose weight, specifically water weight. Okay? We also take this drug in the morning. We don't really take it at night because we don't want them using the restroom, getting up and going to the bathroom all night. It's also dark at night. If you're getting up and going to the restroom all night long and it's dark, you're at risk for falls. Okay. Lasix, these are our loop diuretics. Specifically with our loop diuretics, we really, really want to watch for hypotension. Okay, these drugs also help our bodies excrete potassium. So we need to, usually if your patient's on digoxin, they're also on some diuretic. We want to make sure that if they're on a loop or even a thiazide diuretic, we're watching those potassium levels. Okay, so just keep that whole potassium concept in mind. The only drug that doesn't really excrete potassium is going to be spironolactone, our potassium-sparing diuretic. So this gets rid of all those fluids without getting rid of potassium, which is great if my patient has low potassium. But usually in the hospital, we do blood draws on everyone pretty much every day, getting a CBC, and we want to see what's happening. So if we start noticing my patient's potassium level is through the roof, maybe I need to be a good nurse and advocate to my provider and to pharmacy that they change my patient and put them on a diuretic that's not potassium sparing. Okay, so just keep that in mind as well. And finally, we have mannitol. Again, same concept, getting rid of fluid. What's specific about mannitol, this osmotic diuretic, it's really good at reducing fluid buildup in the brain. So what's this one usually used for? Incidences of increased intracranial pressure, okay? However, a big side effect is pulmonary edema. So do frequent respiratory, cardiovascular, and neurological assessments on these patients. Okay? And now we are going to talk about antihypertensives. Again, please, please, please check your heart rate and your blood pressure. Again, these drugs also can cause orthostatic hypotension, meaning when they stand up, their blood pressure gets really, really, really low. Again, general nursing considerations. Our most common drugs are our beta blockers, specifically metoprolol and atenolol. These are our selective beta blockers, meaning they specifically work on the heart itself to drop your heart rate, drop your blood pressure, and help decrease activity going on. Okay? There are also two other non-selective beta blockers, such as propranolol and acebutolol. Keep in mind, though, what happens if it's non-selective? It means it's 1 and 2. Works on the heart, and it also works on the lungs. So if my patient has asthma or COPD, I need to advocate that they be put on metoprolol or atenolol because those drugs only affect the heart. Okay? Again, monitor your blood pressure before and check your apical pulse, which is your point of maximum impulse, for your heart rate. Okay? Again, you cannot abruptly stop taking these drugs as well. Up next, we have clonidine. This is usually used for difficult to control hypertension, but it's very, very toxic on the liver. And it has, again, those anticholinergic effects, the dry mouth, dizziness, drowsiness, things like that. So watch out for your 3 Ds. Okay? Again, usually with our blood pressure meds, we do not abruptly stop blood pressure or cardiac meds. Okay, it has a rebound effect, meaning if you're taking an antihypertensive and you abruptly stop, you're probably going to have a hypertensive crisis. Okay? Dosins are very, very common drugs. They really are used in combo with diuretics for difficult to control hypertension. Okay? Really, what do we as nurses need to do? I sound like a broken record, but get vitals before, watch for dizziness, drowsiness, fatigue, fall risk, all of that good stuff. Up next, we have our carvedilol, also known as Coreg. This is a really good drug for heart failure. Unfortunately, this can put our patient at risk for hyperglycemia, so we really have to be watching their diet and making sure that we almost put them on a diabetic diet to just kind of reduce overall sugar intake. Again, we monitor heart rate and blood pressure. Up next, we have hydralazine. This is usually for high blood pressure. Specifically, hydralazine is given to a lot of moms who have pregnancy-induced hypertension. It's just the safest one for them, and it works really, really, really well. It's absolutely contraindicated with alcohol, but we need to be monitoring our patient's heart rate. So let's say my patient's normal heart rate is 80. And now their monitor is 120. Okay? After taking this drug, we need to report a sustained pulse of over 20 beats per minute of their normal. So you're with the patient 12 hours a day. If you notice that they're at 70 all day, and then I give this med, and for whatever reason, now their pulse is sustained, it's higher, well, that means that there's some adverse effect going on because my drug's not doing what it should be doing. Also, hydralazine is a really good drug for the African American community because it helps reduce mortality from heart failure. So keep that in mind as well. Again, nursing is all about advocacy. Know your patient, know which meds will work for your patient and what they don't. Just because your patient gets prescribed something, it is 100% your job as a nurse. If you feel that this med might not be safe or that there's a better option, we're the ones that are supposed to be advocating for our patients. Doesn't matter the provider put an order in. If you believe it is unsafe, it is up to you to intervene. Okay? Up next, we have our ACE inhibitors, also known as our PRILs. I always say with these drugs, we really need to be watching our potassium level, okay? Because what can happen with ACE inhibitors, they can cause an increase in potassium, okay? What do we know about an increase in potassium? It causes a decrease in sodium. So specifically with our ACE inhibitors, we want to be watching our sodium and potassium levels. Big common side effect of our ACE inhibitors are our ACE, angioedema, dry cough, and elevated potassium. Specifically, star your dry cough. This isn't just an occasional hack or two. They will have a constant, continuous dry cough. So if your patient reports a dry cough while on these ACE inhibitors, we will actually stop the order and replace them with an ARB, an angiotensin blocker, which we'll talk about now. So our ARBs have the same effect as ACE inhibitors. They're dropping the blood pressure, and they still have that hyperkalemic effect. The only thing with ARBs is that they're just better tolerated. There is no dry cough with ARBs. So if your patient's pretty symptomatic on an ACE, we'll swap them to an ARB. Okay, and again, potassium. What are we concerned about with potassium? We're concerned about some digoxin issues. Okay, so just keep that in mind. Any potassium issue likes to mess with digoxin. Okay, I might make it. It's just the way some drugs interact with our bodies and electrolytes and things like that. Up next, we have our calcium channel blockers, also known as our very nice drugs. What I mean by that, verapamil, nifedipine, and diltiazem. So review what is our non-selective calcium channel blockers and our selective calcium channel blockers. Our non-selective, they work on arterioles and blood vessels. Our selective, they only work on the heart. Our selective blood pressure or calcium channel blockers are nifedipine and amlodipine, but diltiazem, this is non-selective, so it works on everything. What do we use calcium channel blockers for? Hypertension, SVT, things like that. Electrolyte imbalances love to mess with the heart. So we're really trying to calm down electrical activity to calm down the heart. Because we talked a lot about this in Complex Health 1. What happens when the heart gets stressed? It quits. And that's really, really not good. Calcium channel blockers are absolutely contraindicated with grapefruit juice. I always remember calcium is milk. If I were to take a sip of milk and a sip of grapefruit juice, that wouldn't taste good at all. So that's just something I personally use. What is our overdose treatment? Calcium. We have calcium channel blockers, and I have an overdose and I have severe low calcium, I give them calcium. And then again, all of your cardiac considerations, blood pressure before, check your electrolyte levels, things like that. So now we're going to talk about hematological medications, specifically medications that affect blood stuff, if you will. So there's lots of different kinds. When we talk about anticoagulants, with these, we are preventing blood clots, which is fine and well if I have a DVT or something like that, or I'm bedbound and I have lots of factors contributing to Virchow's triad. But what happens if I accidentally nick myself? I'm not going to clot, and I'm going to bleed. So with anticoagulants, these patients are on bleeding precautions, meaning probably no contact sports. I'm not going to poke you more than I have to. And if you insist on shaving, I'm going to give you an electric razor, not a regular razor. The regular razors, that we shave with, that we can nick ourselves with, risk for bleeds. So if they do need to shave, we give them an electric razor, just things like that. And we will have to monitor for therapeutic range. All right, heparin. Really good drug that works really, really fast. Okay? It's usually only used in the short-term hospital setting, okay? This is our bridge to warfarin. If a patient needs to be on an anticoagulant long-term, we put them on warfarin. But warfarin takes time to work, so I'm not going to sit around and wait for warfarin to work. I'm going to put them on heparin in the meantime. Again, we're really just watching for bleeds and hemorrhages, okay? Heparin is really commonly used with AFib, again, as that bridge drug. AFib is composed of clots. That's our biggest risk factor with AFib, or not risk factor, but the biggest risk of having AFib is that you're going to have a clot. So what do we need to do if our patient's on heparin? We need to be monitoring not only their platelets, but their APTT. So we hold heparin if their platelets are less than 100,000, and we also hold heparin if it is over 70, okay? Our antidote for heparin is going to be protamine sulfate. So if your patient's heparin, APTT, is no longer within therapeutic range, and it's like 90, this means that your patient is at big risk for hemorrhaging inside. So we give them protamine sulfate. So just review signs and symptoms of possible over medication with heparin: bruising, rashes, nosebleed, from rigid abdomen, things like that. Lovenox, on the other hand, it's still heparin, but it's low molecular weight heparin, so it's a lot safer. We also give this drug via injection, subcutaneous injection, usually around the tummy for heparin. Again, same use, it's just safer. And with Lovenox, all we need to do is watch the platelet count. We don't have to be looking at the APTT. Warfarin, again, this is our long-term drug. What it can do, it can help prevent an existing clot from getting bigger, and it's also used as a clot prophylactic. So if your patient, again, has chronic AFib, they're usually going to be put on warfarin. When we're talking about anticoagulants, just think, preventing clot formation. This is different than an antiplatelet, okay? And we'll talk about antiplatelets, but we're talking about heparin, warfarin, and Lovenox. Prevents and treats clots. And I believe only our heparin will help dissolve an existing clot. So with warfarin, we now need to be monitoring our INR. We want it to be therapeutic about 2 to 3 seconds. This is our therapeutic INR. Now, if it's 5, I'm at risk for bleeds. So what do I need to do? I need to give the antidote vitamin K. If vitamin K inactivates warfarin, what do I not want to eat a lot of? I don't want to eat a lot of vitamin K because it's going to cause my warfarin to not work. Okay, so keep that in mind. Now we get to talk about antiplatelets. So antiplatelets don't really, they're just not working on that clot formation, on that clotting cascade. What an antiplatelet does is it makes platelets, the kind of thing around the red blood cells, just more slippery so that they slide through each other and that they don't clump up and begin to form a clot. So it's not working on that clotting cascade. This is just making the platelets more smooth, able to squeeze by. Maybe they're super slippery so they can squeeze through tiny little coronary arteries, things like that. Okay. So aspirin. Again, we talked about aspirin being used as an anti-inflammatory and antipyretic, which is great, but aspirin is also very, very good at preventing platelet aggregation. So it's usually given for patients that have chronic stable angina, coronary artery disease, if they've had like a CVA, like a stroke, or maybe they've had a mini stroke, things like that, because this is going to help blood become more slippery so it can slide through and reach all the places it needs to get to. Again, not safe for children, and we can't take this medication with antacids. If you take it with an antacid, the antacid is going to neutralize the ASA, and now you're basically going to have no ASA. So really watch their platelet counts. We want to make sure it's within normal limits. Okay. Up next, we have our Clopidogrel, also known as Plavix. Again, similar concept, antiplatelet, platelet less sticky, means the blood can slide and squeeze into places it needs to go. But a big side effect of Clopidogrel is neutropenia. So we need to be monitoring their white blood cell count. If their white blood cell count is really, really low, we need to call the provider, and they'll probably be switched from Plavix to aspirin. Okay, but again, these drugs put you at increased risk for bleeding. Okay, so keep that in mind. Up next, we have our cilostazol, also known as Pledol. This is really good for atherosclerosis, our PAD, PVD, things like that. It just causes vasodilation and it inhibits clumping. So not only does it widen our peripheral veins, if you will, peripheral vasculature, but it also helps prevent clots. So for patients that have chronic atherosclerosis, intermittent claudication from peripheral artery disease, we're going to do whatever we can to open up that artery and to improve blood flow. So that's what Pledol does. Again, it does take a bit of time to work, so just keep that in mind. And now we're going to talk about thrombotics. So, Altplace is a really awesome thrombotic used for a ischemic stroke in the brain, usually. One thing to note about this drug is there's lots of contraindications and there's lots of protocol we have to go through. Typically, if you start noticing those signs and symptoms of a stroke, again, fast, face, arms, speech, time, things like that, we usually have about 3 hours before we can really get our. You might also hear this drug called ATP. Before we can get this drug to work, there's usually a 3-hour window. However, with this drug, if your patient has any signs and symptoms of bleeds, maybe they had a stroke, fell, and have a massive gash going down their head and multiple different, scratches, they can't get this drug because what happened to all those scratches and those lacerations? Well, clots form to help stop the bleed. So if I have a bleed anywhere in the body, even if it's just a GI bleed, I can't get this drug because it's going to dissolve whatever clot I have. We want it to dissolve the clot up here, but if I have other bleeds, now I have uncontrolled bleeding. Okay, so just keep that in mind. Additionally, if my patient is hypertensive, this drug is also contraindicated. So now we're going to talk about antihyperlipidemics. So our goal is to reduce the bad cholesterol, the total cholesterol, triglycerides, things like that. Why? Diet is super important in preventing a lot of our cardiac disease and other diseases. So review your normal cholesterol panels because this is what we're hoping our drugs are going to give us. By taking an antihyperlipidemic, I'm hoping that my cholesterol panel looks normal or that we're trending in the direction we need to be trending in. Our statins, atorvastatin, this helps lower all of our bad cholesterols. Okay. However, a rare but serious side effect of our statins is it can cause rhabdomyolysis. This is when my muscle tissue begins to just break down, get released into the bloodstream, and then my liver is working really hard to filter that out. It puts me in acute liver failure. So if your patient reports any generalized pain and maybe their urine is having red blood cells in it, those are big signs and symptoms of rhabdo. So we need to be watching for that. Also, if you're on this drug, we don't want you taking any alcohol as well. Okay. Also, we do take this medication at bedtime because it can have a little bit of like a dizziness effect. So usually if we take it more towards bedtime, the patient's asleep before, you feel that. Up next we have ezetimibe or Zetia. This helps lower total cholesterol and LDL. However, this isn't a frontline drug. Usually we try to get them on statins. But if that's not working, we give them this drug. This drug basically makes it really hard for your small intestines to absorb cholesterol, okay? But again, lots of our antihyperlipidemics are pretty harsh on the liver, so just keep that in mind, okay? So yeah. So now I have some practice questions for you guys, in case you wanted to practice some questions with me. So I am going to go ahead and start. And if you guys can go ahead and comment down below in the comments what you think the answer is. Okay? So my first question, A client diagnosed with chronic schizophrenia presents to the ED with uncontrollable tongue movements, stiff neck, and difficulty swallowing. The nurse would expect the physician to recognize which condition and implement which treatment. All right, what are we thinking for this one? So the answer for this one is actually D. So this is tardive dyskinesia. So we have those uncontrollable tongue facial movements. That's pretty indicative of TD. What do we know causes TD? Are antipsychotic medications. So we're going to assume that it's tardive dyskinesia and treat by discontinuing the antipsychotic medications. And they'll probably be put on something else. Maybe a TCA or just a different med, but we know that these adverse effects are coming from the antipsychotic, and unfortunately, it's just a side effect of antipsychotic. So if they're experiencing a lot of these issues, we're unfortunately going to have to switch them to something else. Good job, guys. All right. The next one, select all the statements below that are incorrect about benzodiazepine. So of these 4 statements, what are false about benzodiazepine? So the answer for this one is going to be A, B, and D. Remember, benzodiazepines are CNS depressants. That's why a major side effect of a benzodiazepine is a decreased respiratory rate. Therefore, they should not be used with opioids. What do opioids do? They have a CNS depressant effect. Benzodiazepine has a CNS depressant effect. If we give 2 drugs that lower our that are CNS depressants, we're going to have a low everything, specifically drop in respiratory rate. And finally, D. Narcan is not the antidote for a benzodiazepine. Narcan is an antidote for opioids. The antidote for a benzodiazepine is flumanazole. Okay? But good job, guys. You did well. All right, another one. SSRIs can interact with other types of medications. What medications below should the nurse educate the patient to avoid while taking an SSRI? Select all that apply. And again, the reason we don't want them on all these SSRI stuff is because we want to avoid serotonin syndrome. So the answer for this is A and B. St. John's wort helps increase serotonin levels. MAOIs increase serotonin levels. If we have two meds that increase serotonin levels, I have a very high risk of developing serotonin syndrome, which is what happens when my body has way too much serotonin. And too much of a good thing isn't a good thing. Statins work by lowering the cholesterol. Okay, that's what our statins do. And our benzodiazepines, these really don't mess with serotonin levels at all. They just depress the central nervous system. Okay, so it can be St. John's wort and our MAOIs. All right. A patient with a complicated medical history, including hypertension, AFib, and arthritis, calls the healthcare provider's office to speak with a nurse about all of these bruises she has. Which potential drug interaction should concern the nurse of these symptoms? So what drug combo would I believe my patient would be on if they're telling me they're having lots and lots of bruising? Absolutely. Aspirin and warfarin. Remember, aspirin, antiplatelet. It helps not really prevent clot formation, but how does blood clot? It sticks together. But if I have an antiplatelet and my stuff is all sticky or not sticky anymore and it's slippery and it's sliding past each other, a clot's not going to form. So patients that are on antiplatelets and anticoagulants are at big risk for bleeds. So you guys did really, really well with that question. Just keep in mind, it's not just the it's not just the warfarin that's putting them at risk for bleed. Aspirin and other antiplatelets also put you at risk for bleeds. All right. A father presents to the emergency department with his 4-year-old son. The father explains that his son had a fever, so he gave the child baby aspirin to decrease the fever, but it's not worked. What should concern the nurse about a 4-year-old receiving aspirin? Absolutely, guys. Aspirin has the potential to cause Reyes syndrome in children. Reyes syndrome is a medical emergency. Okay. GI bleed, not great, but livable. Tinnitus, annoying but livable. Hyperglycemia, annoying but livable. Reyes syndrome, no. That is why no child should ever receive aspirin. Even though aspirin has that antipyretic, anti-fever effect, absolutely contraindicated in children. So I have a select all that apply question for you guys. A nurse is planning teaching regarding anti-gout medication. What information should be included? This is about my anti-gout meds. So, anti-gout, what are we thinking? Absolutely, Marco. C and D are one of them. What do we think about A, B, E, and F? Do we think any of those also might apply? So the answer for this one is actually everything, I believe it's everything but F. So actually, well, again, we'll learn more about gout in Complex Health Nursing 1, but we know that an increased diet of vitamin C can actually lower uric acid levels, which is a pretty cool thing. So they're on these anti-gout meds. What do we know about anti-gout meds? They have to be used in combination with diet therapy. So we want to increase our fluid intake because, again, that contributes to that buildup of uric acid. We want to flush it out. We want to take vitamin C. We want to avoid alcohol. We want to avoid foods high in purine. This med can cause an upset stomach. So very good job, guys. All right. Your patient is prescribed hydrochlorothiazide. The patient's potassium level is 2. What medications below should the nurse hold and notify the physician for further orders? Great job, guys. B. Digoxin. Hypokalemia can worsen dig toxicity. Very good. All right. Your patient's taking an ACE inhibitor to manage blood pressure. Which finding below requires immediate nursing action? Awesome job, guys. Remember what ACE inhibitors can do? They can increase our potassium levels. So if I see tall peak T waves on my EKG, I'm thinking hyperkalemia. Something is up with the potassium. Great job. Great job. All right. Your patient is started on a heparin drip. You administer a bolus of heparin and start the drip per protocol as ordered by the doctor. What will be your next important nursing action for a patient who is now on a heparin drip? So the answer is D, correct. We collected APTT level. However, APTT stands for activated partial thromboplastin time. But yes, we need to collect an APTT if you're on a heparin drip. How I know the difference between heparin and warfarin, warfarin is WAR. So I think the R in warfarin and then the INR in INR. So that's how I personally memorize the difference because I always find myself, oh, is it APTT or is it APT or is it INR? So that's just something I use. All right, guys. I have one more question. Your patient is taking simvastatin. Which of the following findings below demonstrates this medication is providing therapeutic effects to this patient? I really like this question because this question style could be on a pharmacology exam or it could be on a med-surg exam. So I love this question. And again, this is select all that apply. Marco is on fire today. It is A and B. Remember, my HDL is my happy cholesterol. I want it above 50. If it's 80, awesome. LDL. I want my LDL ideally above, or below 70-ish. So, thanks, Marco. So yeah, if my LDL is, low, that's really good too. Okay. So yeah, I am very proud of all of you. Thank you so much for coming and attending. I also, for those that recently joined, I just popped in the chat my RSVP link in case you haven't already done so. But does anyone have any questions I could help provide some clarification on?